On behalf of Pharmacists Without Borders Canada, we are pleased to introduce the series titled Cross-Country Webinars During COVID Times. Each webinar will focus on a pharmacist specialty and will discuss how pharmacists from 2 or more countries are working to combat new challenges. Hi, my name is Sabrina Sanzari. I'm Vice President for Membership and Partnership for Pharmacists Without Borders Canada. I am pleased to be joined by 2 amazing pharmacists. Shellyza Sajwani is the current co-president of Pharmacists Without Borders Canada. Shellyza received her master's in pharmacy from Austin University in 2010 and then later received her PharmD from the University of Toronto. Since 2014, Shellyza has been working as an oncology pharmacist at the Ottawa Hospital. As an oncology pharmacist, she has developed a subspecialty in palliative care and works to continue palliative care focus between our oncology patient population. Tarun Nayyar also received his master's in pharmacy in 2010 and then later received his practice certificate in independent prescribing in palliative care at the University of Birmingham. Tarun has been working as a specialist clinical pharmacist in palliative care at the John Taylor Hospice in Birmingham, United Kingdom since 2014. Thank you and welcome to both of you. We are expecting a mixed audience from students to pharmacists with various specialties. I'd first like to ask both of you the following. What is the role of the palliative care pharmacist outside the context of a pandemic?
Hi, firstly, thank you for having me. Just a little bit of background as to my role as a palliative care pharmacist. So I am employed full-time for an adult hospice that's based in Birmingham, and we provide inpatient care as well as community palliative care to patients generally across the east and north part of Birmingham, as well as parts of central Birmingham. My role specifically is split into 2 really. So first, I provide a ward-based clinical pharmacy service to our inpatient unit, which involves spending time with our ward doctors doing ward rounds, providing clinical advice to doctors on prescribing, as well as advice to nurses as well. I do a lot of clinical reviews to make sure that medications that are prescribed are safe and effective, and that medicines that are used in syringe pumps in combination as well are effective as well. So my role is also split into working in the community as well. So I provide home visits to patients who come under community palliative care. Generally, the community nurses are the main focal point for providing community-based palliative care, but they can often pull in other healthcare professionals to provide advice where needed. So the main reason for referring to myself or one of the other pharmacists in our team generally will be for providing support with complex symptom management, and that tends to be things such as pain, for example, which does not always respond to first or second line drugs. But also a range of other symptoms that are complex and difficult to treat, such as breathlessness, nausea, symptoms such as itch, sweating and hiccup. So quite a wide range of symptoms. And we also cover patients who have cancer and a non-cancer diagnosis. So very broad range of patients that we come into contact with in the community. One of the other roles I do in the community is review patients who have syringe pumps, particularly where those medicines in the syringe pumps are often unfamiliar, or where they might need dose titration. So that could include drugs such as octreotide or alfentanil. Also, in my role, as mentioned earlier, I qualify as a non-medical prescriber, which in the UK is quite well advanced now, and it means that I can work more autonomously and actively prescribe medicines following assessment to patients. And that often allows them to receive medicines much more timely and more quickly to help alleviate their symptoms. So I can do kind of this role without having to actively refer to a patient's primary care doctor. As mentioned, it kind of facilitates much more rapid access to medications. The role that I do is quite unique. So there's lots of different aspects of the role, and the role in general is very unique to palliative care pharmacy in the UK. Amongst a lot of my other colleagues who work in palliative care, I'm not yet aware of anybody else who provides home visits to patients who need community palliative care support. Most hospice pharmacists work perhaps 2 or 3 days a week attached to a hospice, or they may be based in a hospital trust and provide inpatient palliative care support. So I think the role I do is a bit unique, and I think we're very lucky, as well, I'm very lucky to be in the job that I'm in at the moment.
Thank you. Shellyza, what about you?
Okay, so as you mentioned earlier, I've been working as an oncology pharmacist since 2014. I've developed my palliative care subspecialty, which basically means that along with working in oncology, I'm also working to keep a palliative care focus, both within outpatient and within inpatient oncology. Currently, I'm working within inpatient oncology. So what does that mean? That basically means that from the time that a patient gets diagnosed with a metastatic disease to the time where prognosis is kind of determined, and then all the way through to end of life on the palliative care unit on inpatient oncology, we're really looking to continue a seamless palliative care focus. And that, therefore, tries to bring together the palliative care and the oncology part of this. So part of this also involves the selection of chemotherapy, looking at what supportive care this patient should actually be on at this time. When somebody then becomes NPO and we're looking into deprescribing, how can medications be discontinued safely? And also earlier on, how do we also reduce the pill burden as well? On the palliative care unit, I'm involved as just basically also an extra pair of eyes in terms of looking at CAD pumps and managing opioid rotations as well. But also in conversation with the generalists and with oncologists, I'm also involved both with my oncology expertise and trying to continue the palliative care focus.
Great, very interesting. How has your palliative care practice changed with the pandemic? For example, in terms of people choosing palliative care or advanced care planning question?
I think a lot of the focus in the UK early on during the pandemic was on aggressive and early hospital assessment and intervention. For example, with assisted ventilation, supportive care. The demand for intensive care beds was also being quite high, and there perhaps wasn't the foresight until later on in the pandemic as the kind of important role that palliative care plays in a disease for which we currently have not got a cure. But clearly there are a lot of patients who live with advanced malignancy or non-malignant illness for whom transfer to hospital would not be in their best interests. And we're now having more discussions about advanced care planning, about preferred place of care and the preferred place of death for these patients. One of the things we're also trying to do is to increase awareness amongst our palliative patients as to what their expectations would be from an admission to hospital, and having sensitive discussions with them as well about the nature of intensive care. And these conversations are quite difficult to have in the context of COVID-19, not least because of the implications of family members living with patients who might be positive and who may well be actively dying at home. There are also other barriers as well that have arisen. It's quite difficult to talk about advanced care planning and have those very sensitive discussions over the telephone. As a profession, we're quite used to visiting patients at home, or at least having these conversations face to face, and being able to spend the time with families, relatives, to talk about advanced care planning issues. Without the availability of full PPE, however, that's another aspect. We can't always safely conduct home visits. And I don't think that advanced care planning is quite conducive to working as part of telemedicine. I've noticed an increasing number of patients are willing to have these discussions and make their wishes known. And with a greater number of patients who wish to stay at home and not be transferred to hospital for management of COVID-19, there comes a need to make sure that we have access to medicines which can provide timely relief of distressing symptoms such as breathlessness or delirium or agitation at home. In the geographical area in my practice, that's involved more prescribing of injectable medicines to preempt these symptoms, as well as more joint working with retail pharmacies and other pharmacy colleagues in the community to source drugs and make sure that we can deliver them safely to the most vulnerable patients at home as well. I think from a general perspective, a lot of the things that have changed in terms of my practice is being able to deliver more education to staff, so staff of all different professions, on things like different routes of administration, on how COVID-19 symptoms can present, particularly as patients deteriorate, and the kind of symptoms that professionals should be looking out for in the end of life phase, and how quickly patients are expected to deteriorate as well. So there's a lot more education as well been involved in COVID-19, and making sure that other people know the kind of role that we can play as well to help these patients.
Okay. Shellyza, what about you? How did the pandemic change your practice?
Yeah, so I would agree with Tarun in a lot of points. I would say that advanced care planning is very difficult at this stage, especially when you consider that when patients are admitted to hospital, generally we have a no visitors policy unless it's a very exceptional circumstance. So for example, if death is foreseen very imminently within the next, I don't know, day or so. So it's very difficult to have these conversations as well with the family joining in on the phone. The idea of family meetings, for example, really everything basically changes. The other thing that I would say is important from an oncology perspective is that it also, I think that COVID also influences what treatment path one may choose. So for example, a patient may want to minimize the number of times that he or she is visiting the hospital. Now for appointments, those can often be changed to virtual telehealth appointments if they're just for follow-ups. But for chemotherapy, of course, it may actually change what type of chemotherapy one patient may want to end up choosing. The discussions also have to happen earlier as to end of life. Does one want to have end of life within a hospital palliative care unit perspective versus at home versus a hospice? And there's a lot of regulation as to when a particular institution may accept a patient from the hospital as well. So I find that advanced care planning has just become so much more tricky. I would definitely agree with Tarun in this area.
Tarun, what is the guidance provided for treating symptoms for COVID?
So the main guidance has come nationally, and it's from the National Institute for Health and Care Excellence in the UK. They published guidance quite early on in April on managing symptoms of COVID-19 in the context of end-of-life care. Given the amount of limited evidence that we had to hand back then on which to base our formulations or to formulate recommendations for symptom management, much of the guidance has been pretty much derived from expert opinion by specialists who work closely with hospitalised patients and those approaching end of life. A lot of the symptoms that are covered include things such as cough, breathlessness, anxiety, as well as delirium and agitation, which has often been noted in these patients at the end of life. And it also includes advice on non-pharmacological management where appropriate to clinically consider. There are recommendations made on PRN or as required dosing, as well as suggested doses of medicines to be administered via syringe pumps for continuous subcutaneous infusion. A lot of the doses are based on the British National Formulary, which is pretty much known worldwide, and the Palliative Care Formulary, again, which is a very specialist palliative reference text, but well known worldwide as well. A lot of the drugs and doses that are in there are very much familiar to what palliative care professionals would already know. Interestingly, one recommendation does suggest that when planning supplies of anticipatory medicines for patients who are deteriorating, there should be some consideration given to using other routes of administration, such as sublingual or PR routes. And that's obviously an area where we as a profession have quite a lot of significant expertise in, and where we can advise appropriately other healthcare professionals, and where we can support our colleagues who work in hospital and hospices. And the other thing to mention is that we may also need to consider using medicines off-label or out of license, which in the UK could include things such as oral olanzapine or dispersible olanzapine for nausea, or things like granisetron patches, again, which would be used off-label. So lots of recommendations made within the guidance, and that is the main guidance that I think most organisations are following in the UK.
Shellyza, what is the guidance provided for palliative care and medical oncology?
So that's a great question. The first thing that I would note is that for individuals who are entering palliative care and are therefore having a first look at medical oncology patients, Pallium Canada is a great first resource. It's basically a resource for palliative care professionals, but it has a great introduction to medical oncology as well, including how to manage oncological emergencies. The two references that I tend to go to the most are looking at the ASCO and the ESMO websites. So for ASCO in particular, they've provided some guidance on triage and on specific detailed guidance when it comes to each disease site and how to manage with each disease site also within a pandemic setting. ESMO has also a page on practical suggestions when it comes to averting the risk of exposure. So also ensuring the appropriate supply of analgesics, maximizing telemedicine. They have an emergency palliation protocol for non-ventilated COVID patients, which is very useful. And they also have some guidance on how to further reduce febrile neutropenia risk. As Tarun was referring to, they have some guidance on nausea and vomiting as well. And very importantly, how to manage anticoagulation in patients in this setting as well. And they include and specifically focus on patients with metastatic disease.
In your practices, has this pandemic impacted guidance regarding shortages of drugs?
So drug shortages in the UK tend to affect different regions of the country, depending on things like wholesaler supply contracts. We've had several alerts that have been sent to hospital and palliative care teams about shortages of drugs. They're not necessarily been influenced by COVID, but obviously in the context of COVID, they are important. So one of the alerts we had, which came back in March and April time, was around a shortage of diamorphine, 5 milligram and 10 milligram ampules. So that's a drug we would use more so in the UK than perhaps in other countries abroad. But that's an issue that's not yet fully resolved. We've also been made aware of an alert which has told us that lorazepam injection has been unavailable as well, because Pfizer, who's the main supplier of the drug to the UK, is experiencing a supply issue. So although that's not necessarily a formulation that we would use a lot of in palliative care, that might have knock-on consequences on the availability of other drugs which we would use in palliative care, such as subcutaneous midazolam. Through other palliative care pharmacist colleagues, we've had reports raised that methadone injection is out of stock as well until June at the very earliest. So there are a few shortages which have the potential to impact on patient care. One of the pieces of guidance that was published in the UK about 3 weeks ago now was from the Association of Palliative Medicine, which is quite a big representative body for palliative care medicine specialists as well as other healthcare professionals. They published some guidance along with our Chief Pharmaceutical Officer and other NHS organisations on priority medicines for palliative and end-of-life care during a pandemic. So the main aim was for palliative care specialists and chief pharmacists to work collaboratively to review and consider reallocating supplies from clinical areas where use of those drugs was less. So they provide first and second line options for common symptoms such as pain, breathlessness, anxiety, delirium. The list is by no means exhaustive, and wouldn't include all the drugs and symptoms that we might be able to anticipate, but at least it helps coordinate kind of the additional demand that might be anticipated on certain drugs. The guidance itself might well be managed to slightly differently at local levels, depending on what local formularies keep as first and second line drugs in stock. So there is some flexibility, for example, for what one hospice may use as first and second line, that they can then interchange those, like haloperidol or levomiprazole for agitation, depending on obviously what they may use more often. One of the things that was published a few weeks ago also was a national standard operating policy that the UK government published, which facilitated the reuse of medicines in care homes and hospices. So I think they were anticipating that the hospices and care homes might have faced shortages of critical drugs. So they were then put in place a policy that would allow reuse of drugs which weren't already being used. So that was only expected to be applicable for a very short amount of time, because obviously we don't routinely reuse medicines that have been dispensed for another patient. Obviously, typically controlled drugs tend to get destroyed after a patient's death as well. But this obviously provides a framework for hospices and other palliative care units to be able to safely reuse drugs if needed.
And Shellyza, what's the situation in Ottawa?
So for hospital pharmacists, including myself at the Ottawa Hospital, the primary place where we would go to consult in regards to updated information about medicine shortages is the individuals in our workplace responsible for inventory control, including management as well. And they basically send out a weekly email on what are the medications that we really need to be concerned about. And then we do a review of our current patients, including the patients on the palliative care unit as well, along with the general inpatient oncology ward. So far, I would say that the biggest influence, I would say, has been on IV antibiotics. This, of course, from my setting, of course, ICU has been impacted more. IV antibiotics is kind of an obvious one as patients come in with respiratory symptoms, for example. They'll be put on some kind of empiric regimen. So that has been my main concern. I haven't found so far, as of today, a big influence on the medications that we use for palliative care. However, when I was looking into this in more detail, I noticed that the CSPCP has released a summary of identified issues. They, however, particularly focus, similar to Tarun, on palliative care within the out-of-hospital context and within the community setting. So I found that that was very, very interesting when one thought of the link of hospital to community and just managing discharges and thinking ahead.
Thank you very much to both of you. I'm sure our viewers will really appreciate this webinar.
Thank you, Sabrina. Sabrina, again, is our PSF Vice President for Membership and Partnership. I would say that if anyone is interested in getting involved with Pharmacists Without Borders, please feel free to contact us using either our website or our social media. This is the first of several sessions focusing on cross-country conversations through the pandemic. Each time we will be looking at a conversation between a pharmacist from outside Canada and a pharmacist from inside Canada about a particular specialty in order to improve knowledge exchange and also build new relationships coming together through these difficult times. Thank you, everyone.
Thank you.
Thank you.